Bismillah ar-Rahman ar-Rahim. Dear colleagues, it's my pleasure to introduce this presentation in the course of Egyptian Society of Cardiology. I'll talk about left-right shunt, percutaneous and surgical options. First of all, the shunts are divided into pre-tricuspid lesions like ASD, atrial septal defect, and post-tricuspid lesions like ventricular septal defect, beta ductus arteriosus, endocardial cushioning defect, aortopulmonary window, coronary AV fistula open into the right side of the heart, and perforated sinus of Valsalva. The endocardial cushioning defect and aortopulmonary window are treated by surgical options, while others can be treated by either mode of treatment. The complication of left-right shunts due to pulmonary overflow, it may cause recurrent respiratory infection, heart failure, arrhythmias, and paradoxical embolization, pulmonary hypertension, which may eventually lead to Eisenmenger syndrome, and infective endocarditis. In addition to these complications, cardiomegaly may occur due to these shunts. In ASD, the right side is dilated, and VSD and BDA, the left side is dilated. This scheme shows the progression of pulmonary arterial hypertension at the acinar arterioles due to persistent volume and pressure overload. Normally, it is composed of one layer of the endothelium and adventitia. When there is volume or pressure overload, there is new muscularization, swelling of endothelium cells, and proliferation of the endothelium and hypertrophy of the media. This stage is the reversible stage, at which when we close the defect, everything will return to normal. But if untreated, there is progression, proliferation of the endothelial cells, fibrosis of endothelium and adventitia with inflammation and plexiform formation, which may occlude the arteries at this level, which may cause severe pulmonary hypertension, and this will be reflected on the right ventricle, increasing the RV pressure, which may cause right to left shunt and systemic desaturation. At this stage, surgical or percutaneous closure may cause is contraindicated. It may cause high mortality or severe intractable right ventricular failure. How to assess reversibility in pulmonary arterial hypertension and congenital heart disease? One of them, the age. The age below which reversible pulmonary arterial hypertension is likely is 6 to 12 months in case of atrioventricular septal defect, endocardial cushioning defect, TGA, and truncus arteriosus. It is less than 1 to 2 years in case of BDE and VSD. In ASD, at the age of 30 or 40 years, we may find patients with these shunts. Most of them are at the reversible stage. The irreversible stage or severe pulmonary hypertension in ASD is rare because mostly it is volume overload, not pressure overload. The comorbidities, if these comorbidities are present, it may cause early and severe pulmonary hypertension, and the patient may have irreversible stage earlier than other patients, like Down syndrome, congenital diaphragmatic hernia, bronchopulmonary dysplasia, and others. On physical examination, when we find that there is cyanosis at exertion or peripheral oxygen saturation less than 90, clinical signs of pulmonary hypertension like right ventricular heave, accentuated second sound, or fading of ventricular murmurs, it is fever irreversibility. On echocardiographic examination, if we find that there is left-right shunt and the pulmonary to systemic flow ratio is 2 to 1, it is indicative of reversible pulmonary arterial hypertension. On hemodynamic study by cardiac cath, if the pulmonary vascular resistance index is 4 Wood unit per meter square, it is reversible. If it is more than 8, it is irreversible. If it is 4 to 8, it is in the gray zone. It needs further evaluation, what is known as acute reversibility test. We do acute reversibility test using nitric oxide or ibuprofen. So after this administration of this medication, if there is decrease in the pulmonary vascular resistance of 20% or less, the pulmonary vascular resistance index become less than 6 Wood unit per meter square, it is reversible. If there is a reduction of about 20% in the ratio of pulmonary vascular resistance to systemic vascular resistance by 20%, or the final ratio is less 0.3, this is indicative of reversible pulmonary arterial hypertension. In ASD, the ASD, one of the most common congenital anomalies seen in adult patients, because it is just volume overload. It causes right side dilatation, and the pulmonary hypertension on those patients mostly not reach the irreversible stage. The larger the lesion, the higher volume overload and more symptoms. In children, we can find that the patient has exercise intolerance or failure to thrive or recurrent chest infection. In adults, the presentation mainly arrhythmias, mostly atrial fibrillation, beside right side dilatation or paradoxical embolization, with which result into stroke, and also pulmonary hypertension. As we know, patients with small defects less than 1 centimeter in size may remain asymptomatic till the 4th or 5th decade of life. So we saw many patients in 3rd or 4th decade with ASD, but they haven't Eisenmenger syndrome. Rarely, in about 5 to 10%, they have irreversible pulmonary arterial hypertension. So when we evaluate the ASD patients, we have, if the diameter is 3 to 8, it mostly will close by the age of 1.5 years. But larger than 8 millimeter rarely close spontaneously. You have to consider this when we take our decision. The amount of the shunt in ASD depends on the size of the defect, RV compliance, and LV compliance. So in older patients, when the LV compliance increased due to age or systemic hypertension or diabetes, coronary artery disease, the compliance of the left ventricle increased, which result into more left to right shunt and more symptoms. This is the ASD. This is the interatrial septum structure. It's composed of septum secundum from the right side, the floor with fossa ovalis in the middle, the floor of which made of septum primum on the left side. This fossa ovalis is the true septum. The secundum ASD occurs at the site of the fossa ovalis. We have other types of ASD, like primum type at the AV valve, the sinus venosus type at the SVC or IVC, and coronary or unroofed coronary sinus. All these types are treated by surgery except the secundum type ASD. ASD, as we know, the clinical findings are minimal. We just have ejection systolic widely split and fixed second sound. The right side dilatation is seen in the ECG, chest X-ray, and echo. In the case of primum ASD, we can diagnose this defect by echocardiography. It is very close to the AV valves. And by ECG, we can find that the patient have right bundle branch block and left axis. This is characteristic of these patients. And the sinus venosus defect, as SVC, it is usually associated with anomalous pulmonary venous drainage. Also, this patient should be treated by surgical approach. What is the recommendations, the guidelines for transcatheter device closure of secondum ASD if it is hemodynamically significant ASD with suitable anatomic features? Class 2A, if there is transient right to left shunt that cause paradoxical embolism resulting in stroke or TIA, or this shunt may cause transient cyanosis, these patients are considered class 2A indication. Class 2B, small ASD, secondum type ASD, in patient with at risk of thromboembolic events, like patient with transvenous pacing system, or chronically indwelling intravenous catheters, or patient with hypercoagulable state. Class 3 indication, if it is a small, hemodynamically insignificant, and other types of secondum ASD like sinus venous defect or primum type ASD or unroofed coronary sinus. Also, if there is advanced pulmonary vascular obstructive disease. The transcatheter closure of ASD, we have to evaluate the defect properly regarding the rims all around the defect, the site of the defect, it should be secondum type, sure. The rims all around the defect. Rims are the rims at the AV valve, which can be appreciated at 0 degree by TE, and in opposite to that is the posterior rim. The retroaortic rim can be appreciated at 35 degree, and posterior inferior rim opposite to that. Bicaval rims at the superior vena cava and inferior vena cava can be appreciated at the 90 degree. Also, the coronary sinus rim at 140 or 150. All rims should be present, except the anterior superior rim, which is the retroaortic rim. So, what are the exclusion criteria? Insufficient rims less than 5 millimeters, except the retroaortic rim. Maximum defect diameter more than 36 millimeters. The total septal length less than the left atrial disc diameter, or if there is partial anomalous pulmonary venous drainage. We have to give aspirin for this patient before and after the procedure. We give for 6 months aspirin and Plavix also for 1 month. We give warfarin if the patient have atrial fibrillation. The procedure done under general anesthesia with TE guidance. We give heparin and prophylactic antibiotic. How can we choose the device size? We have to, it depends on the size of the defect, rims all around, thickness and length of these rims, retroaortic rim present or absent, shape of the defect, circular or oval, and the total septal length. Initially, we used the sizing balloon in all cases, but nowadays we use it in special cases or difficult cases only. We inflate low pressure balloon at the site of the secondum ASD. We measure the diameter at which the color flow stopped by transesophageal echo. This diameter is correspond to the device which we'll use. If we depend on the echocardiography in determining the size of the device, in children we use device size same as the defect diameter if the defect is small with adequate rims. If it is large or there is deficient rims, we can use device 1 to 2 millimeter larger than the defect diameter. In adults, we have to measure from firm to firm edge. If rims are adequate with the device size 2 to 3 millimeter larger than the defect diameter, if there is no retroaortic rim or deficient rims, we upsize to 20%. If the shape is oval, we average the size. This is the ASD occluder. It is a self-expandable device made of 19 hole. It has 2 discs and centrally there is a waist. The 2 discs are, the left atrial disc is 14 millimeter larger than the waist. It is available in different sizes and introducing sheaths. This is the technique after introducing the sheath into the left upper pulmonary vein over a super stiff wire. We deliver the left atrial disc in the left atrium guided by the transesophageal echo. We pull all the system to the septum and then open the right atrial disc, and we do wiggling technique to be sure if the device is stable. And after evaluation of the stability and relation to the nearby structures, we disconnect the device. Also, if we have multiple fenestrations, multiple atrial fenestration, we can use a special device. This is multiple fenestrations. We can use the cribriform device. It is same like the ASD occluder, but the connecting waist is very narrow. These defects should not be closed, like flimsy rims, as you see here. The IVC rim is flimsy and hypermobile, although it is long, but it is hypermobile and unstable. Large defects like this one, 39 millimeter, or deficient rims like this, like posterior rim here, it is deficient. So these cases should not be closed. BFO closure as a cause of cryptogenic stroke in young patients, we have to exclude atherosclerosis first, and exclude thrombophilia, and exclude also atrial fibrillation. And to demonstrate right to left shunt by saline contrast echocardiography and contrast enhanced transcranial Doppler. And the technique is similar to ASD closure, as you see here. The difference of the device of BFO, the right atrial disc is larger than the left one. An elderly patient with ASD, they have special problems like pulmonary hypertension. We have to investigate the pulmonary vascular resistance very well, atrial arrhythmia, AV valve insufficiency, right side heart failure, comorbidities, but the most importantly, the masked LV restriction. Those patients have advanced diastolic dysfunction of the left ventricle. If we close the ASD, the patient may have significant pulmonary congestion or pulmonary edema. So we have to investigate this. We have to evaluate LV end-systolic pressure before we close the ASD. And if there is significant rise, we can prepare those patients by medical treatment, or we can use fenestrated device. Although the complication of transcatheter closure of ASD is rare, but it is significant. The residual shunt, one of these complications, embolization. So this patient, the operator should be well oriented by snaring technique, like in this patient. Erosion is very important. If the patient came to the clinic or the emergency room by chest pain or pericardial effusion, we have to think of erosion. It is fatal complication. we have to take it seriously. It may occur early or late. It is associated mostly in patients with absent retroaortic rim or large devices. We have to send this patient immediately to surgery to save their life. Other complications are rare. We finished the ASD. We shift now to the BDA, patent ductus arteriosus. As we know, it is commonly seen in premature infants. In the clinical presentation, maybe clinically silent duct detected only by echocardiography, a small duct. There is murmur, but hemodynamically insignificant. It doesn't cause cardiomegaly or pulmonary hypertension. Moderate sized duct, we may have continuous murmur, left ventricular dilatation, and a degree of pulmonary hypertension. Large ducts may result into Eisenmenger syndrome. If there is Eisenmenger syndrome, there is no continuous murmur, and there is differential cyanosis and clubbing. The recommendation for transcatheter BDA closure class 1 is moderate size or large BDA with left-right shunt, which may cause symptoms like congestive heart failure or failure to thrive, or that cause left side dilatation with or without pulmonary hypertension. Class 2A, if it is small and audible. Class 2B, if there is bidirectional shunt at the level of the BDA, but reversible with pulmonary vasodilator. If it is small and unaudible also, it is considered as class 2B. If there is severe pulmonary hypertension that unresponsive to pulmonary vasodilatation, it is class 3. This is the BDA. Most common type is conal shaped. The BDA device also is specifically designed to accommodate or to adapt it to the shape of the BDA. According to the shape of the BDA, we can choose the device. In the cone-shaped BDA, we can use the AD1 or BFN coil, and in the window shape, we can use ASD or VSD, and the tubular shaped BDA or these shapes of BDA, we can use the vascular plug or the ADO2. We evaluate the BDA in the angiogram in lateral projection and in the REO. We measure the diameter. The technique of closure is by introducing the sheath over suprastiff wire after crossing the BDA from the pulmonary artery to the aorta. We introduce the sheath from right side through BDA to descending aorta, and then we introduce the basal duct occluder in the descending aorta and withdraw the whole system to the BDA position. With angiogram, we be sure that the device in position with no residual flow, and then we disconnect the device. If the pulmonary ente is too small and can't cross by the large sheath of basal duct occluder, we use this coil, which can be introduced through 4 or 5 French catheters. Also, if the BDA is tubular like this one, we use the vascular plug. We reach the end of this presentation, and I will present in the next lecture the VSD and other shunts, and I hope it is useful for you and all of us. Thank you very much.